Hey guys, this is Austin Nakatsuka, and I'm just going to demonstrate here a case of a posterior capsulotomy that I did for a young patient, a primary posterior capsulotomy that I did for a young patient to avoid a PCO. So this is a young patient that I can't tell the exact age, right? I'm not allowed to tell you the exact age, but it's a very young patient that would be difficult to be doing a YAG capsulotomy laser in the clinic. And so for these, if we have to do a cataract surgery, um, we do a primary posterior capsulotomy. And essentially, I'm just going to blaze through the actual cataract surgery itself really quickly here. But that's to avoid, of course, an opacification that we're going to have trouble doing a laser YAG capsulotomy in clinic. So I'm going to show just quickly how I did that here. So this, as you can see, is kind of a posterior PSC slash polar type of cataract here that we had a lot of debate over whether or not this cataract should actually be done. I initially turned it down quite a few times um, and had a lot of discussion with the pediatric ophthalmologist, but eventually I did decide that it should be done. And so here um, there was actually a small nick, I think, that happened in the posterior capsule. Yeah. So when we took it all out, we noticed a small opening already. So yeah, it might have been a posterior polar nose adherent. So this is kind of in real time, or at least pretty close to real time. And I know it seems real slow because I'm going really, really slow to kind of very gently make a little opening there because, as we know, the posterior capsule is far thinner than the anterior capsule, so it's very easy to split open and you don't want anything to happen there. Now, when we're doing a posterior capsulotomy, a lot of people state, okay, you know, what you're supposed to do is actually not have viscoelastic in the bag, and you should have viscoelastic in the sulcus, and you should have the anterior and posterior capsule kind of stuck together with no viscoelastic in between. And the reason for that has to do with a lot of tension and dynamics of the capsule. And and it tends to work better that way. Now, I didn't do that in this case. I think part of the reason was because the capsule was already slightly open, and I just felt that I wanted it to be, I wanted tension to be on the posterior capsule immediately in the bag. So I'm just kind of keeping viscoelastic in the bag there. And as you can see, I ran into a little scar there from the, I guess it was a posterior polar capsule, and so I had to actually cut it with this MST scissors. So I'm cutting that quickly to remove it. And there, you can see a little opening there, and essentially that opening serves as the posterior capsulorhexis. And I left it just like that, and in and that's kind of how you do a posterior capsulotomy, or this is a demonstration of a posterior capsulotomy. And I was able to still put a lens in the capsular bag. And this one, okay, so people are wondering, why are you doing a multifocal in a young patient? I was very much against this initially too, but the parent really, really wanted to try this in this patient, and they had amblyopia, and they wanted to try a multifocal in the bag there. And so I went ahead and did it. And and it's basically to try to give some form of pseudo accommodation for that patient. And that patient is actually doing really well with it. And they have amblyopia there, so the vision's not like substantially better, but they're improved and they like the lens really well. So this is an example of doing a posterior capsulotomy, a primary posterior capsulotomy with a multifocal lens in the bag. And that was a small one. And I'm sorry, I take it back. I may not have planned that initially, but we did have a small little tear there, so I went ahead and did it in this case. But you can do this as a primary capsulotomy planned for really young patients like babies. Hopefully that was sort of interesting, and let me know if you have any questions. Thanks.